Morning, everyone. On behalf of Health for the World, it is my pleasure to introduce you today to Van Nguyen. Dr. Nguyen obtained his medical degree at Morehouse School of Medicine in Atlanta and continued his radiology residency at Maine Medical Center. He then completed his vascular interventional radiology fellowship at Brown, where he currently works as an associate professor. Thank you so much, Dr. Nguyen. Please take it away.
All right. Well, thank you very much. Like Dan said, I'm Dr. Nguyen. I'm currently one of the interventional radiologists here at Brown. Thank you so much for having me speak today. And just wanted to, give a shout out to Dr. Rahani and all of her team for just an incredible effort to get this off the ground and implement it the way that they have done. And so honored to come here today and give this lecture. What I'll be speaking about is portosystemic pathways and interventions. This is something that is, from the standpoint of the portal venous system, kind of taking a back seat as, far back as, medical school, where you're just learning a little bit about the anatomy, but not really understanding, the physiology and how it truly relates to the systemic venous system. But being an interventional radiologist, we are dealing with a lot of pathology that is related to underlying portal hypertension in a patient population who have cirrhosis. So understanding portal hypertension and physiology and how it relates to the systemic circulation takes on a greater importance. So today, what I'm going to be talking about includes just an overview of portal hypertension, the underlying flow dynamics, and how it relates to the portosystemic pathways that exist, how it shows up on imaging, and then some of the complications that arise from it, as well as some of the interventions that can be performed in the presence of certain complications, okay? Some of these medical illustrations were done by one of our medical students, which you can kind of take a look and enjoy here. So we know that, from the standpoint of the portal system, you're dealing with drainage from the mesenteric veins, the superior and inferior mesenteric veins, joining the splenic vein and going to the portal system into the liver. So from that standpoint, there's not really a macroscopic, easy communication from the systemic side to the portal side. So that doesn't really show up until patients start developing portal hypertension, okay? And we know there's multiple causes of portal hypertension, but understanding and knowing your portal anatomy and where flow goes and where flow can sometimes decompress is important for the recognition of typical and atypical locations for variceal development, okay? And variceal development is important because those sometimes can undergo or encounter complications. So when we talk about portal hypertension, what does that mean? Just increased portal pressure. Technically, it's defined as portal pressure gradient, which is the difference between the portal vein and the hepatic side of 5 millimeters or greater, okay? 5 millimeters of mercury or greater. So just as a general, graphical depiction of what causes portal hypertension, by far and away, the most common reason for portal hypertension is in the setting of cirrhosis, okay? Setting of cirrhosis, which causes, hepatic sinusoidal dysfunction, all right? But we know that, outside of the intrahepatic causes, there are, less frequent, rare causes of portal hypertension from a post-hepatic side, Budd-Chiari syndrome. On the pre-hepatic side, any type of portal venous thrombosis or splenic vein thrombosis can cause portal hypertension. And that makes sense, right? The flow goes from the left over to the right. And if you have any sort of blockage on this side, there's going to be increased pressure back to the left side there. So As portal hypertension progresses, okay, your body is, has a beautiful mechanism to try to compensate for any sort of difficulties. Okay, so as the hypertension increases, blood flow starts to change direction in an effort to compensate for that. And it can go from hepatopedal, which is towards the liver, to hepatofugal, which is away from the liver. When the portal pressure gradient, we talked about a gradient of greater than 5 is considered portal hypertension. Around 8, collateral vessels start to develop at different sites of communication between the portal and systemic circulations to help decompress. And that's when you start to see it on imaging and recognize different areas of variceal development, okay? So, like I said, as the body tries to compensate for the increased portal pressures, we start to see what we call, spontaneous portosystemic shunts, okay? So this is just your body's efforts to try to decrease flow within the portal system and divert it into the systemic system. Something that's very, very common that we see is the periumbilical shunt, or what sometimes people call the recanalized umbilical vein in the setting of portal hypertension. Okay, is seen in up to 30% of patients with portal hypertension. What it truly looks like at the pathologic level are dilated periumbilical veins in the falciform ligament. All right, so how does it decompress? Well, it goes from the communication, generally is from the left portal through those periumbilical veins, down the epigastric veins, superior and inferior epigastric veins along the superficial abdominal walls into the external iliac or femoral vein. That's how you kind of get this caput medusa appearance. But here, on a CT, you can see it very nicely, all right? You can see the dilated periumbilical veins, and then as it travels down, the epigastric veins, and then finally goes down there and hooks into, in this instance, goes into the right common femoral vein there. Another common spontaneous portosystemic shunt is the splenorenal shunt, seen about 14 to 20% of cirrhotics. It may clinically present with hepatic encephalopathy, which makes sense, right? As your body is trying to decompress itself, well, what it's doing is diverting flow that originally was supposed to go to the liver, where it gets filtered, detoxified. So you have a lot of free ammonia that has gone from your gut, avoided or been diverted from the liver, and has gone straight into the systemic circulation. And when you have a lot of free ammonia levels in your systemic circulation, well, you can clinically present with hepatic encephalopathy. Okay, splenorenal shunts are associated with portal vein thrombosis, right? Looking at the anatomy, as the splenic vein joins in with the mesenteric veins to form the portal vein, if you have any sort of blockage on the portal side, well, then you're going to get increased pressure on the left side and cause potential varices and shunt development there. And here you can kind of see on CT, a large splenorenal shunt is evident as it hooks into the left renal vein there. Here you can kind of see on a coronal view what that looks like, okay? And this patient also had splenic vein thrombosis. The gastrorenal shunt is something that is also commonly encountered, seen in a vast majority of those with gastric varices, okay? These are the ones who show up sometimes with upper GI bleeding, hematemesis, and on CT imaging, you see large gastric varices there. But something we look out for, particularly on the interventional side, is, okay, if this patient is bleeding, how can we get there? How do we get there? And since a lot of these patients have gastrorenal shunts, we look for that. because that is potentially how we can get to that area to potentially treat it. And here is an example on a coronal view of a large, nice looking gastrorenal shunt. This is something that is a shunt, but not particularly related to underlying cirrhosis or portal hypertension. But something that's worth noting is this, what we call the hot quadrate sign, right? Or the hotspot sign on nuclear medicine. But you have this segment 4 hepatic pseudolesion. And that's something that can show up in the setting of underlying SVC obstruction, which can be due to either cancer or a benign stricture from prior repeated central line placements. But essentially what you're looking at is shunting of flow through the superior vein of SAPI into the left portal vein. So here on the CT of the chest, you can see this patient has underlying chronic thrombosis of the SVC due to lung cancer. And this is just a graphical depiction of the flow as it goes down the internal mammary vein through the superior vein of SAPI and dumping into the left portal vein. That can lead to what we call downhill esophageal varices, as there's engorgement of the esophageal venous plexus. Okay, and that'll lead me to esophageal varices. Okay, so what we've talked about just before now has been all about these splenorenal shunts, right? I'm sorry, all these portosystemic shunts that have formed in the face of increasing portal venous hypertension. But now, once you get to the point of decompression to decompensation, you start to have to deal with complications, right? So esophageal varices are present far and away the most common type of varices in the setting of cirrhosis, seen in about 40 to 80% of cirrhotics. Once you get to a portal pressure gradient above 12, you're at high risk of variceal bleeding. Okay, so these patients commonly present with hematemesis or with brisk enough bleeding. They have melena. All right, so this is just an image, coronal image showing what the esophageal varices look like. Here you can kind of see what that looks like. The other part to notice on this picture is the enlarged azygous vein there, which is a known portosystemic pathway of esophageal varices. So actually this patient underwent percutaneous access into that portal vein. Here you can kind of see as it fills up the esophageal varices, dumps into the azygous vein at that point, okay? So gastric varices are less prevalent than esophageal varices, but at the same time, there's a higher mortality rate when bleeding occurs, and they are notoriously difficult to manage endoscopically. The reason for that is that gastric varices are larger. They're larger than esophageal varices, and the larger they get, with Laplace's law, surface tension, wall tension gets greater and greater. And when they do rupture, they're very, very difficult to manage endoscopically. And if you look at this, if you can look at these varices, there's a lot that are both in the subepithelial layer as well as in the submucosal layers too. So to be able to go in and actually treat them by injecting or ligating them endoscopically, you're probably missing out on a lot of different varices that are beyond the scope of what you're actually seeing. So that's part of the reason why they're so difficult to manage that way. And that's why sometimes they come to us. So that patient I showed you with the bleeding gastric varices, on imaging, you see it. You see the gastrorenal shunt here, and you see these large varices. So, if these patients are faced with the prospect of, a high mortality rate, well, then we have to do something about it. So knowing that there's a good portosystemic pathway here, what we do is we go into the systemic side, right? So for this case, we actually went in through the right femoral vein, but you can also go from the jugular approach. But we go from the right femoral access into the IVC and then navigate into the left renal vein and then into the gastrorenal shunt, okay? A gastrorenal shunt or any shunt is trying to push flow back into the systemic circulation. So because of that, the visualization of these varices can be extremely difficult. And that's the reason for the basis of what we call the procedure called the balloon-occluded retrograde transvenous obliteration, which is what we call the BRTO procedure. The balloon occlusion is necessary to be able to push flow back into the varices so that you can actually see it, as well as trap the treatment when you are engaging in some sort of embolization of these varices to keep it all from flowing out. And here's just an example of when we go into it, what that looks like. So this is the balloon catheter, and as we inject it with contrast, you can see the varices filling, all right? And I'll stop it right here, and you can actually take a look. Something that you also have to look out for as the interventionist, and knowing all the different communications that may not show up on CT, but is evident when you pressurize the system, are other areas of systemic communication. Here, once it fills in, you start to see the ascending and transverse segments of the inferior phrenic vein, and that is a known communication to the IVC right here. And then not only that, but you've got communication here, which is the pericardial vein that goes all the way up and joins in at the junction of the subclavian, the left subclavian and brachiocephalic vein there. So those are things to look out for. And why do you look out for that? Well, you want to be able to make sure that when you are engaging in some sort of treatment, that you know exactly where your embolic agents are going and whether or not it's going to be effective, right? You don't want to lose everything you're putting in to some sort of pathway, escape route. And you also want to make sure that the stuff you're putting in doesn't go back into the circulatory, into the systemic system, up into the pulmonary arteries and cause a big pulmonary embolus. So those are things to look out for. Sometimes these escape routes are big enough where you may have to go in through the internal jugular vein or other systemic route and try to plug it up also prior to performing any sort of treatment. All right, so what we do to treat this is with sclerosis. And so to be able, with varices so big, you want to be able to formulate something that has a large volume and has a large surface to wall contact ratio. So what we do is we make a foam mixture of air, sodium citrodecol, which is a sclerosant that causes an inflammatory response along the vessel wall and causes it to thrombose. We mix that together into a foam, but we also add Lipiodol. And Lipiodol is necessary for us to actually see this medication go into the varices because Lipiodol is radiopaque, okay? So we put that in, and then you go, well, once you put it in, what do you do? Well, there's literature out there where people leave the medication in and leave their balloon up for anywhere from an hour to 24 hours. But that's not feasible a lot of times with the patient turnover. So what we do is, for this case and a lot of other cases, is we put coils or plugs into the gastrorenal shunt outflow right here to plug it up to allow the medications to sit in there and not escape back into the systemic circulation. Okay, follow-up imaging. It's important to know that the medication, the cocktail we put in, is radiopaque because of the Lipiodol and the gas bubbles, the air that we mix in. So you're going to see little pockets of gas within these varices. It doesn't mean that there's some sort of potential infection or things like that forming. Okay, so Lipiodol, also known as thiodol, is derived from poppy seed oil, is used as a radiopaque contrast agent, which we mix in with any sort of embolic material that can't be seen on the fluoroscopy. It will be radiodense on non-contrast CT. Here you can kind of see what that looks like. All right, so if you are looking to determine if there's any residual filling of your varices, a non-contrast followed by a contrast-enhanced CT is going to be helpful to determine it, because if you go straight to a contrast-enhanced study, you may not be able to tell what's actually Lipiodol and what's actual residual filling, okay? Something to think about when you're looking at follow-up imaging is looking for signs of worsening portal hypertension, right? It makes sense in that you are plugging up what your body has tried to do in an effort to decompress the portal system. So by going up and treating something that is going to potentially kill that patient that day, which is the bleed, what you're doing is also sacrificing what your body has tried to do over a long term. So in an effort to reduce mortality, you may increase morbidity. So by plugging up these shunts, what you can do is worsen the portal hypertension. And so in a large group of these people with gastric varices, after these procedures, they can have aggravation of their esophageal varices, okay? Seen to, and probably about 40% of people can have aggravation of their esophageal varices. Probably about 7 to 10% of people can start developing ascites. And here you can kind of see this patient who did not have ascites prior to procedure started to have that after. But again, that's not something that's going to kill the patient. So that's something that we have to look at the pros and cons of doing. And a lot of times what we also do is combine these procedures later on with a TIPS or a transjugular intrahepatic portosystemic shunt in an effort to decompress that portal system and decrease chances of, you know, esophageal bleeding or ascites down the road. Okay. So that leads me to the topic of ectopic varices, right? The most common, most frequent varices are going to be in the gastroesophageal arena. But once you jump outside of that, you got to think about, you know, how we find, see, and treat ectopic varices, okay? They do account for up to 5% of variceal bleeds. And, you know, in terms of prevalence, you know, they're scattered throughout the mesentery and retroperitoneum, involving duodenum, jejunal areas, rectal, as well as peristomal areas. They can come in with hemodynamically significant hemorrhage or intermittent bleeding that doesn't respond to any sort of medical or endoscopic treatment. There's not real good standards in literature about how to treat these. So you kind of have to get creative and also treat these patients how they present clinically. So this is just an example of an ectopic varices that actually was found almost incidentally, but did not undergo any sort of treatment, but coming in with right upper quadrant pain. And so here you look on under ultrasound, no good flow in the main portal vein. On these next two images, you start to see hypervascularity within the region of the gallbladder fossa and around the gallbladder, you know, along the periphery of the gallbladder fossa walls there. And on CT, it's pretty evident that there are gallbladder varices, okay? Varices, and then right here is just an arrow on a large portal vein thrombus. And again, you can kind of see on this image, the varices forming around the gallbladder. Just something that's good to know, good to recognize, and also know that, you know, up to 30% of people, when you do identify gallbladder varices, have some sort of underlying portal vein thrombus. So if you see one, make sure you look out for the other, okay? Because the cystic vein dumps into the right portal vein branch, all right? So when you have a blockage there, you can form these varices. This is a patient actually we treated, a known cirrhotic, had a history of a left lower quadrant ileostomy and recurrent bleeding around the stoma. So Peristomal varices, as we said earlier, probably around 20% prevalence in terms of ectopic varices. The approach to it, to get there, well, there's not a really great portosystemic pathway to this. So, and these are also superficial enough to be seen under ultrasound. So this is actually a case where the patient was bleeding around the stoma, wouldn't stop. So what we did was we went in with ultrasound. But the important part with ultrasound is that, you know, tracing out the pathways can be quite difficult under just ultrasound. So once we get access into it, we use fluoroscopy with contrast to make sure that we know exactly where our sclerosant is going, and making sure that it's not going into an area that we don't want it to go. So this is just a case of both a combined ultrasound and fluoroscopic direct sclerosis of peristomal varices. So this is a patient and has a history of peritoneal carcinomatosis and IVC thrombosis. This doesn't necessarily have to be in the face of underlying cirrhosis or portal hypertension, but it's good to be able to recognize this. This patient actually had IVC thrombosis. So in a similar vein, no pun intended, as SVC thrombosis, this patient developed retroperitoneal varices, okay? So depending on contrast filling and the timing of the study, it may not light up in the way where it's easily identifiable as a vascular structure. So it's just good to be able to recognize this as part of your differential diagnosis, and know that, you know, sometimes they can be confused for adenopathy or masses, and you don't want to be going and biopsying something like this. So this is a patient that actually presented to the ED with hematochezia and abdominal pain for a day, was becoming increasingly hypodynamically unstable. So a GI bleed protocol was performed. So, you know, when we do the three-phase CTA, what we do is a non-contrast segment first to make sure that you can see any sort of hyperdense material or calcifications. And then we do the CTA, which is the angiographic portion of it. And then we do a delayed phase. So here you can kind of see how difficult it is to see any sort of underlying vascular abnormality. But on the delayed phase, here you can kind of see there's actually filling of numerous varices around the third portion of the duodenum. And so this patient actually had bleeding duodenal varices. And take a look here. And then, so this patient doesn't have a great systemic pathway to those varices. And if you look right here, there's colon adjacent to the liver there. So how do you get to it? So knowing our anatomy, we say, well, if we can't get through it through the portal system, we'll go through the spleen and into the splenic vein. Okay, so we've got percutaneous transsplenic access into the splenic vein and then down into the superior mesenteric vein to be able to find those varices. And here you can kind of see what that looks like. And the brisk bleeding into the duodenum is very, very evident as you see the filling of the varices, but then all the contrast spilling and filling the duodenum, and you can kind of see the nice outline of the valvulae convergentes of the duodenum there. Okay, so this patient was in trouble, but we were at the right place at the right time and was able to embolize this nicely and completely. My partner, Dr. Sanan, did this, but used a combination of essentially glue, N-BCA glue. We mix it again with Lipiodol to be able to visualize it well under fluoroscopy, okay? So here you kind of see the glue mixture coming out and filling these varices. We were able to achieve complete embolization, and the patient was able to see the light of another day. This is a case of a 44-year-old male with recurrent bleeding rectal varices, multiple prior failed endoscopic treatments, as well as he was encephalopathic. Now you guys are thinking about, looking at all these varices and says, well, why don't you just go and do a TIPS? Well, from a TIPS standpoint, not everybody is qualified, or at least is a good candidate for a TIPS procedure. And somebody who's encephalopathic it's a relative or sometimes even an absolute contraindication to a TIPS procedure, because you are creating a shunt from the portal side to the systemic side. So putting a TIPS in for this patient may help with their bleed, but at the same time may worsen their encephalopathy. So you have to be creative in terms of trying to find out the best way to treat these patients. You do want to decrease the portal systemic gradient, but at the same time, you also want to make sure that you're not putting them in a worse position than when they started. So for this patient, what we decided to do was go directly into those varices. And here you can kind of see what the contrast enhanced CT looks like. Here you can see large varices down into the rectum here. So without a obvious portosystemic shunt or communication for us to go into, we decided to do a percutaneous transhepatic route into the portal vein, and then from the portal vein into the inferior mesenteric vein, and then down into the superior rectal vein and into the varices. Okay, so here you can kind of see what that looks like. This is just a portal venogram demonstrating the SMV, the splenic vein, and then kind of the little plump inferior mesenteric vein there. As we go all the way down to the superior rectal vein, we're able to do an injection and see the large extent of all the varices there. So how do we treat it? We treat it the same way we treated those gastric varices, with a mixture of air, sodium sotradecol, and Lipiodol. We coiled the inflow into the varices right there, just to trap everything and make sure that nothing continues to flow in and washes all the stuff out. But essentially, we got a good result. And 6-month follow-up colonoscopy, you can see how distinctly different the mucosa looked compared to the prior colonoscopy. So we got a really, really great outcome on this study. All right, so this is actually one of my favorite cases, where it was a 78-year-old male with a history of gross hematuria and known, or he was told he had a bladder mass, right? So he went to an outside hospital for recurrent hematuria, and this is back in 2019. He got a CT urography study. So CT urography study showed this lobulated lesion along the bladder wall. On the contrast enhanced portion, it enhanced, right? So he was told that he had what looked like probably a large aggressive cancer. Wasn't sure exactly what the workup or at least the interventions were, but he kind of bounced around until whether it was a good thing or bad thing, he's had massive episodes of gross hematuria that landed him in the hospital requiring multiple transfusions. All right. Urology did a cystoscopic evaluation, saw some bleeding vessels along the wall of the bladder, but tried to treat it with injections, but nothing was very durable. Thankfully, though, a repeat CT was obtained. And here you can kind of see he had a history of non-alcoholic steatohepatitis. So he wasn't an alcoholic, but he does have underlying cirrhosis. And as we go down here, you kind of see how large this inferior mesenteric vein is. And then here, it's quite evident that that previously described bladder mass is actually huge varices along the bladder wall, okay? And that was responsible for his gross hematuria. And you can kind of see on coronal view what that looks like. And I just point out this arrow right here just to kind of show you how little of the varices actually show up on the bladder wall. So you can kind of see why, you know, sometimes endoscopic or cystoscopic treatments can fail, right? You're looking at the tip of the iceberg when everything else is outside of the bladder wall here. And see, here you can kind of see on the sagittal view, you know, a urologist goes up cystoscopically and looks around, sees some of these bleeding ones and just kind of injects. But literally, it's really just a drop in the bucket compared to everything out here. So it's actually kind of funny in this patient, you know, the urologist called me and said, you know, I consulted general surgery, consulted vascular surgery. No one knows what to do with this guy. We thought it'd be a nice last ditch effort to call you guys. So I said, I think it's kind of funny because I think IR would be the only group or the only division that could do something for this patient. So go ahead and send them over to my office because we do this all the time. Then I went and searched the literature. Turns out we don't do this all the time. Actually, in the history of this world, I think we've done it like twice. So got a little nervous, but I started reading a little bit more about it. It's an this is what we call portal hypertensive vesiculopathy, okay? Only a few reported cases in the literature. There are a couple of cases that's been written up of endovascular access and embolization that was described in Korea and Japan. Nothing in the Western literature. But if you think about it, you know, it's very rare because when you have portal hypertension, you're going to have a lot of decompression into the splanchnic, you know, pathways, and there's a large volume enough there to compensate for that. So for something to actually form around the urinary bladder is very rare. But digging into this, talking to the gentleman, he had a history of prior pelvic radiation for prostate cancer, as well as some prior nodal resection. So I think that there's probably an underlying anatomic proclivity there for bladder varices to form, and that was exacerbated by his underlying portal hypertension. But regardless, we know our anatomy and we know how to get there. So that's what we engaged in, despite the rarity of this case. So prior to doing anything, I put an ultrasound probe on his urinary bladder just to kind of see if I could actually see those varices. So here you can kind of see 4/16/21. So over a year went by where no one was really helping him. He was at home thinking he was going to just die of cancer. But he comes to us and we try to help him here. So got direct transhepatic portal access into that there, okay? Once we get into it, you go, okay, all right, what are we looking at? What are we seeing here? So here we go. All right, a large, massive, tortuous inferior mesenteric vein there. And then once we get into the IMV, there you go. It's important to see here, though, there's communication into the iliac and IVC too. So it's important to be able to recognize those types of things, because if you are going to engage in some sort of therapeutic, you want to say, okay, what are my reasons for potential failure? And what are my reasons for potential complications if I do send in particles or some sort of embolic material, okay? So we put a balloon up and did, again, repeat venogram to outline the entirety of the varices. And then once we put in the foam, STS, which is the sodium sotradecol mixture that we use for the rectal varices as well as the gastric varices, plugged it up with coils, and you can kind of see what that looks like. And then for good measure, we added glue into the coil pack to make sure that it was as occlusive as possible. And this is just a final run demonstrating the vast improvement of the embolization. And then, as we were putting in the foam, we were watching with ultrasound, and here you can kind of see all the varices filled with air there, and it's flowing around there. So 6-week follow-up CT was very satisfying to see from the standpoint of the eradication of those varices. The bright stuff is a combination of coils and the Lipiodol, but here you can kind of see what that looks like. And then on the contrast phase, again, you see how there are almost no varices still left there. So this patient has been someone I've been seeing in my clinic and saw him 2 weeks ago. And since that procedure has not had any more hematuria and is very happy. So it's a very satisfying case to go from someone who thought he was going to die of cancer to living pretty much a normal life right now. So that was one of my fun highlights of this past year. So in summary, I just want to say that, understanding the hemodynamic alterations in portal hypertension will help with, the recognition of common portosystemic pathways, as well as seeing ectopic varices on imaging. Just know that, the typical locations of atypical varices can be mistaken for mass lesions or adenopathy on CT, depending on contrast phase. So it's good to have, at least on your differential, when you are looking at these things, particularly a patient with underlying cirrhosis, to know that, hey, even though it's not lighting up like varices, could these be varices? And do I want to make sure they're not varices before I recommend some sort of direct tissue sampling, okay? And then identifying visible portosystemic entry and exit points on imaging can be extremely helpful to your fellow IR for procedural planning should endovascular intervention be undertaken, because we are always looking for creative ways to go into the portal system. And I think that knowing all the entry points, exit points is helpful, because we are going to make sure that we don't harm the patients if we do engage in some sort of intervention, okay? And these are my references and acknowledgements, and happy to take any questions or comments at this time.
Dr. Nguyen, thank you so much for this comprehensive review of portosystemic pathways. The cases were excellent. The last case I was mind blown. I've never seen that. I didn't know that was possible. We are going to give it a couple minutes for the audience to put in any questions that they may have. In the meanwhile, I do have one question.
Yeah.
You were mentioning that higher venous pressure gradients increase the risk of bleeding, right? I was wondering if there were any other ancillary imaging finding that require a prompt IR management.
Well, a lot of these patients, I will tell you, a lot of these patients come to us not from an imaging standpoint, but usually come to us from clinically managed under, usually a gastroenterologist, urologist, or things of that sort. So really, when we are seeing these patients, they are generally just funneled to us because these patients have presented with a certain clinical scenario. These patients generally are managed endoscopically before any sort of imaging is identified. Now, from the standpoint of endoscopically, when you look for things like, stigmata of recent bleeding, spot signs, dots, things of that sort, in a patient with a history of prior, ligation, prior treatment, and at risk for higher bleeding, what happens is these patients then go down the pathway of imaging. Okay, so essentially, you know, what are you looking for anything specific on imaging? You're seeing signs of portal hypertension. There's really no good correlation, okay, between what you're seeing and how a patient's actually presenting. Okay, so from that standpoint, what we do, just like, you know, management of upper GI bleeding, right? Sometimes when a patient comes to us for upper GI bleeding, we may not see anything angiographically, but if the guy is bleeding out, you know that, hey, at this point, I'm going to have to go in and do something because this patient is bleeding out in front of my eyes. And you sometimes can embolize, say, the gastroduodenal artery without actually seeing active extravasation. So the balance of how a patient clinically presents to you is going to truly push you into a direction of what IR is going to engage in. But we, the imaging standpoint provides clues, but there's no real, you know, red flags that kind of say this is about to happen or that's about to happen.
Right, right. Thank you so much. So we have two questions. The first one is, do the portosystemic shunts ever recur after intervention?
Yes, they can recur from the standpoint of, just like, you know, any sort of embolization procedure, you're going to have possibilities of incomplete embolization. And when we talk about, you know, earlier when I was showing you the gastrorenal shunt, right? So the gastrorenal shunt is pretty evident on CT imaging, but that's just a passive imaging process with contrast going into the veins, filling it. So if you are not well aware of other pathways, what we call efferent and afferent veins that go into these shunts, as you pressurize it, I showed you a couple of those small areas that went back into the systemic circulation. Your body's natural inclination is to use what's there. So do we see other shunts forming? Yes. Is there recanalization of an area that has previously been embolized? Potentially, if the coiling, if the procedure was not effective enough, those areas can open back up.
Okay, thank you. And then the other question has 3 questions. So thank you for the excellent presentation. For the last patient, was there a leak of embolic material into systemic venous drainage?
That's a very, very great, yeah. Okay, I'm sorry, was there a third question?
So the question reads, was there like a leak of embolic material into systemic venous drainage identified pre-embolization? When would it be contraindicated to perform the procedure when systemic veins feel pre-embol?
Yeah, so I think that's a great question, and we have a couple of cases like this in the rectal varicose arena, where the communication into the systemic circulation is quick, where so brisk that you go, oh my God, what are the risks here? Okay, so it is important for pre-procedurally or pre-embolization to be able to delineate where the pathways are, okay? Just like any sort of procedure that we do, you want to make sure, you want to weigh the risks and the balance the risks and the benefits. This past, the last case, yes, when we did see any sort of communication into the system, the systemic venous system, the important part is estimating volume, okay? Estimating volume before you see that. So what we do before we embolize is we do an angiographic run with a preset amount of contrast in our syringe, inject it. As we see it filling, Once we start to see, filling of the systemic system, you stop and you look and you say, okay, I went through a volume of X number of cc. So you kind of get a good estimation of when the system fills to a point where it starts to dump into the systemic circulation. If it is something where the filling and the dumping into the systemic circulation becomes a concern, where it's a large type of communication, what you may be forced to do, which we have done, is go into the systemic side and come in, find our pathway where they both communicate, and plug that up with a balloon. Fortunately, as we're able to measure the volume, as we're able to put our medication in, once it goes out and starts filling, what happens is there's a quick inflammatory response. With that inflammatory response, things start to shut down. And when it shuts down, that also restricts some of the outflow. So you're watching this under fluoroscopy the entire time. And so, yeah, we are, it is something where we do have to be cognizant of the fact that you are sending stuff into the systemic circulation. So if a patient starts to cough, starts to have oxygen desaturation, you just have to stop and think, okay, is what I'm doing sending everything out there? But luckily, the cases, these cases, nothing of that sort happened, but we have had to go into the systemic side to plug it up.
Thank you so much. And the fourth question just arise.
Yep.
Will you perform TIPS after embolization as a durable treatment for portal hypertension? Yes.
And so, if you look at the current literature out there, there's not a great deal of mortality benefit by performing TIPS with these embolization procedures, but there is a clear morbidity benefit. And so I think for probably almost all of these patients, we ended up doing a TIPS. We ended up doing a TIPS just because of worsening portal hypertension, right? Basically, having ascites, things of that sort. And like I said, you're trying to, when these patients are coming to you, with being transfused, low blood pressure, and bleeding out, well, the important thing is to stop the bleed that day. But once you kind of regroup, you say, okay, let's make sure that this patient, doesn't have any contraindications to a TIPS, okay? And, let's try to fix this from a global perspective, right? Because it seems a little contra-intuitive a little bit to say, well, if the body is trying to have a shunt to help you out, why are you messing up the shunt? So so the combination of it is probably going to be the way to go going forward in terms of how to treat these. But most of these patients ended up getting the TIPS.
Thank you so much. Someone from the audience was wondering if you could share your email address. They want to ask you something offline or connect.
Yeah, sure. Happy to do that. Would you be able to post that, my email address?
Definitely post it or send it directly to the person that was asking.
Yeah.
We're getting thank yous, many great presentations. So thank you so much, Dr. Nguyen. It was a very, very good talk. And we hope to have you again in the future.
Yeah, very, very cool. And like next week, I was going to say next Friday, my colleague Mahesh Jayaraman has an excellent talk on stroke. And he's one of the neuro IR guys who taught me everything I know. So tune in. If you thought today was cool, next week's going to be a million times better. Okay, so don't miss that at all.
We won't. Thank you so much, Dr. Nguyen. Bye-bye.
Awesome. All right. Have a good day, guys. Bye.
You too. Bye-bye.